Hello, everyone. Welcome to our webinar, Demystifying and Destigmatizing Suicide. Today's webinar, we will explore the common suicide myths, how to use destigmatizing language when talking about suicide, and basic tools that we can use to respond to someone who discloses thoughts of suicide. Please be aware this webinar will be recorded and available on the Care for Caregivers website. If you experience any technical issues, please use the QA box or send us an email to webinars@safecarebc.ca. The chat function is disabled. Only QA box is available to participate and ask questions, please. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the land, which we each call home. I want to start by recognizing that we are gathered on the ancestral and unceded territory of First Nations, Inuit, and Métis people across British Columbia. We thank them for being good caretakers of the land and allowing us to be visitors of this shared territory to do good work. This free webinar is brought to you by Care for Caregivers, an online mental health resource for healthcare workers and leaders in British Columbia. It is a joint initiative of the Canadian Mental Health Association, BC Division, and Safe Care BC, funded by the Ministry of Mental Health and Addictions. I'm joined today by Maria Weaver, the Associate Director of Suicide Prevention and Life Promotion at the Canadian Mental Health Association BC Division. She is a skilled, enthusiastic leader, educator, and facilitator with many years' experience across sectors, including higher education, nonprofit, and community health. With her experience working frontline and later managing a crisis line, she is adept and compassionate in providing crisis de-escalation, mental health promotion, and suicide prevention training and education. Please use the QA box to ask questions and to participate. Thank you, Maria, for joining us today, and I'm going to turn it over to you now.
Great. Thank you so much. And thank you so much for having me this afternoon. Let me just get my sharing up and running here. Perfect. Thank you. Awesome. So thanks everyone for joining us this afternoon. I want to acknowledge that it's lunch hour for most of us. So really appreciate you taking time out of your busy schedules to have a really important conversation today about demystifying and destigmatizing suicide. Some of you might know, maybe others not, September is actually Suicide Prevention Month. So September 10th, which was our last Sunday, was World Suicide Prevention Day. So this webinar is, partially brought to you as part of the Caregiver for Caregivers initiative, and also has been kind of specifically chosen for today based on the proximity to World Suicide Prevention Day. So really important. I think this conversation is important any day and any month, but particularly in September, to take this opportunity to kind of open these conversations and to learn more about suicide and its prevention in our community. We are also, CMHA-BC and the Crisis Center of British Columbia in Vancouver have actually partnered as well on a social media campaign through the month of September for World Suicide Prevention Day and month. So if you are looking to learn more after today's webinar, you want to check out some of the resources that we've been sharing, I'll share our social media links at the end of the webinar as well. I also, like we said earlier, please make sure you're using the Q&A feature for questions. I am going to leave space for questions at the end. So the questions about tech will be answered as we go along, but anything related to the material, we've got about 10-15 minutes at the end to do a Q&A as well. And I really wanted to kind of start off just by kind of setting the scene that I'm hoping today will be kind of a branching off point for folks. So really taking the time to kind of get an intro to this topic with the hopes that folks are feeling inspired by the end to kind of do some further learning and perhaps invest in some further training around suicide and its prevention. So we started off already with a bit of a land acknowledgement, but I also wanted to acknowledge where the work of CMHA BC takes place. So our offices are located on the traditional lands of the Musqueam, Squamish, Tsleil-Waututh, Lekwungen, and Wyoming nations. And I'm specifically joining today from the traditional lands of the Lekwungen and Wyoming nations. So joining from Vancouver Island in Victoria, BC. I do always like, in addition to my land acknowledgements, to provide not only an opportunity to respectfully acknowledge and reflect upon the history of the land that we're situated on, but also an opportunity for us to do some learning together as well. And the first piece of learning that I'd love to pass along to folks today is one that I believe I learned through Dr. Tyler Black, who's fantastic, does a lot of work in the suicide prevention sphere as a psychiatrist. And this is around the reframing of the language of risk. So we often hear when we talk about suicide, this idea of suicide risk factors. And you may have heard before people use the kind of phrasing that being Indigenous or indigeneity is a risk factor for suicide. The reframe I'd like to provide folks with today, though, is that indigeneity itself is not an inherent risk factor for suicide. What we know is that Indigenous communities in our society can be disproportionately impacted by suicide, but this is not due to cultural or identity factors. Rather, this is due to structural inequities that result from things like racism and colonization. So I'd really encourage folks to kind of take that learning forwards and encourage that reframe when you're hearing that language being used. So rather than using that term indigeneity as a risk factor, we can be instead saying that Indigenous communities may be disproportionately impacted by suicide due to structural inequities resulting from racism and colonization. I also wanted to highlight a wonderful approach to suicide prevention that has been developed and really spearheaded by groups of Indigenous youth in our community. And this is the idea of life promotion. So a few years back, there was an initiative that was launched by Indigenous communities with the help of Indigenous youth to talk about ways in which we could help to prevent suicide in Indigenous youth specifically. And one big point of feedback that came up from these Indigenous youth is that folks were feeling like a lot of the conversation around suicide prevention in Indigenous youth communities was really centered on this idea of death and of dying, and almost left these youth feeling like they were kind of inevitably fated to think about suicide at some point in their life. And they offered this idea of a reframe and encouraged the promotion of something called life promotion, which is really a community-based approach to suicide prevention that in the context of Indigenous communities really encourages people to strengthen their connection to life, strengthening connection to land, community, self, spirit, and really equipping folks to live a long and prosperous life. So really kind of changing that focus from death and dying to ways in which we can promote things that really connected people to life and living. So there's a great website called Wise Practices that I encourage folks to check out after our webinar if you're interested in learning more about life promotion. And I really do believe this is a very, very important approach to suicide prevention. And those of us on this call, myself included, that are not Indigenous, I think we stand to learn a lot from our Indigenous partners in this area of work. So really would encourage some further learning there for folks who are interested. So I already got a bit of an introduction, so I'm not going to bore you folks with my name and my title again, but just wanted to share that I've been doing this work with CMHA now in this specific role for about 6 months. And my portfolio does encompass all of the work that we're doing in British Columbia around suicide prevention and life promotion. So part of that does include workshops and webinars like what we're doing here today, but also leading some kind of community-based work as well as some work with our regional health authorities around suicide care quality improvement. So if you are interested in any of that, my contact info will be shared at the end of the session. You are more than welcome to follow up with me after today as well. I want to own off the top too that we do all come to the topic of suicide with diverse professional experiences working with suicide, but also our own personal experiences with suicide. For some of us, this might be a super easy conversation. Maybe we've talked about this before. It's super comfortable to kind of engage in this learning material. For others, that may not be the case. This may be a topic that brings up certain feelings or thoughts that might get in the way of engaging safely or participating in a comfortable way. If that's you, that's okay. It's totally normal. Many of us have been impacted by suicide. And please know that you're welcome to take a step back, take leave from the call at any point. If you do need support at any point in time, I've highlighted some resources here. These are 24/7 resources available in our province, so accessible at any time of day. So where are we headed today? We're going to start by talking a little bit about suicide in Canada in general. So really kind of painting the scene of how suicide impacts our communities. We're going to then talk about reducing stigma, so ways in which we can kind of open up these conversations. We're going to talk as well a little bit about what we can do to help, finishing off with some resources, and then, like I said, leaving some space for Q&A at the end. And I just want to remind folks again, we're only here together for an hour. I think we're going to do lots of great learning together, but there's so much more that we can learn about suicide and suicide prevention. So I would encourage folks, if you finish this webinar and you're like, oh, I wish the what we can do to help section was longer, there are some amazing training opportunities that I'll highlight for you folks where you can get some more of those kind of concrete, further fleshed out helping tools. So the World Health Organization has actually deemed suicide to be a matter of public health. So something requiring intervention and prevention on the kind of public scale. We know that according to Stats Canada, we lose more than 10 Canadians every day to suicide, which averages out to almost 4,500 people annually. We also know that for every death by suicide, there's 25 to 30 suicide attempts, roughly 5 self-inflicted injury hospitalizations. And we used to say that every suicide death impacted about 5 to 7 people. But what we know now from more recent studies is that for every person who dies by suicide, as many as 135 people can be impacted in one way or another by the loss. Stats Canada actually also ranks suicide as the 9th leading cause of death in our country overall. And I was really surprised to learn about this fact, particularly because suicide actually ranks higher than conditions like kidney disease. And what I find most interesting about that is we have no problem talking about kidney disease. We speak about kidney disease very easily. If somebody's grandparent, for example, was going and having care for their kidneys, they'd probably talk about that quite openly. We don't necessarily have the same here with suicide in our healthcare systems. We also know that suicide deaths are underreported. So these statistics are likely to be actually more inflated if we were to kind of know the full story behind certain deaths. We know that it can be quite challenging to determine whether a death was a suicide or not. And due to things like stigma as well, we know that sometimes folks will actually cover up that the cause of death was suicide. So these stats are an approximation, but are likely to be kind of more inflated if we were able to kind of get that full picture. So at this point, hopefully it's clear to folks that suicide impacts many of us. I would argue possibly all of us, either directly or indirectly. And really, that begs the question, why do we struggle to have these conversations right now? What is it that's getting in the way of talking openly about suicide? And I would argue that really a lot of what that is that suicide is still highly stigmatized in our society. So it's something that we really have ascribed a lot of fear to, a lot of negative sentiments. And, there's a reason for it. It makes sense when we know the history of how suicide was viewed, and we'll talk about that in a bit. But really, we want to get to a place where we're able to kind of dismantle that stigma. We want to be able to talk safely and openly about suicide, because what we know is that is actually one of the best ways to help prevent suicide, is to have these conversations clearly and openly. So what can we do to reduce stigma? We're going to talk about a couple things that we can do as helpers, whether that be in our personal lives or even in our workplaces, to help reduce the stigma that surrounds suicide. One of the ways that we can start to kind of dismantle suicide is using what we would call suicide-safe language. So what you'll start to learn as you look at the language we use surrounding suicide, that a lot of the language and the terminology we use to describe suicide actually comes from a highly stigmatized past. And for many of us, this is no longer intentional. It's just kind of become embedded in our commonplace language. But I think it's really important for us to learn, where does this language come from, and what kind of mistaken ideas might we be kind of unnecessarily perpetuating by using this language. So many of us will have heard the terms that somebody committed, or I have committed suicide, or somebody commits suicide. What we actually know about this term is that the term to commit or committed suicide actually harkens back to a time when suicide was a criminal offense. So if you were somebody that had attempted to take your life, you survived your suicide attempt and sought help, you could actually then be incarcerated or charged for having a suicide attempt. So we know this is a very stigmatizing and loaded word. When we think about committed, one of the only other times we use that word in common language is to talk about committing a crime. So we really want to reframe that language. Instead of saying that somebody has committed suicide, we want to speak factually and clearly and directly about suicide and just say that somebody has died by suicide or there's been a death by suicide. Once you are aware of this, you're going to start to hear this term commit or committed suicide all the time. So would really encourage, it takes practice. I know it took me a little while when I first started working at a crisis line to kind of catch myself in these moments and redirect, but would really encourage folks to kind of try to catch this in ourselves and also in those around us. We'll also hear the terms sometimes where we'll actually describe a suicide attempt as being either successful or unsuccessful, or perhaps completed or failed. And again, what we're doing here is we're kind of unintentionally ascribing value to the death by suicide. When we think about a successful suicide, meaning a death, when you really start to unpack that, we don't really want to be encouraging the fact that a death is a success. Same with the opposite. When we think about a failed suicide being that somebody has lived through a suicide attempt, we don't want to ascribe the value of failure to the fact that this person has actually lived and has another opportunity to get support. So instead, we want to stick to that clear, direct, factual language. We want to say that somebody either died by suicide or that they survived or lived through a suicide attempt. You can even use the terms fatal or non-fatal. So you could say that there was a fatal suicide behavior or a non-fatal suicide attempt to describe the same concept. In the mental health field, which I'm sure some of you kind of work in this space as well, we're a big fan of what we call person-first language, which is what this first kind of row is really highlighting. So when we talk about person-first language, it's using language that describes, when we're describing an individual, we're not ascribing a condition or a state to their entire being. So when we think about saying John is suicidal, we're really describing John as the whole person as being somebody that's suicidal. What we really know, though, is that this person, John, is much more than just their thoughts of suicide. And so we want to reframe that to using descriptors that peg their thoughts of suicide or their experience with suicide as just that, an experience, a thought, a scenario, something that they're dealing with in amongst the holistic context of their life. So we would say instead, John is thinking about suicide, or John has experienced thoughts of suicide. Harkening back to what we said before as well around kind of this idea of at-risk people or high-risk populations, we can use person-first language here as well. When we say somebody is a high-risk person or an at-risk person, it kind of gives that sense that we're saying this person might be a ticking time bomb for suicide, or, is at any given moment, suicide might impact them. We know, though, what really is the case is that there are populations where they may have higher rates of suicide, or populations that are disproportionately impacted by suicide. So a small reframe, but one that carries a lot less of kind of that value assumption or that stigmatized connotation. I've got some great resources here. I'm not sure, hopefully the Care for Caregivers team is able to kind of send these out as well. But if folks are interested in, why language matters, wants to kind of remind themselves about what we learned together today, there's a great resource by CAMH, not CMHA, CAMH. They're a different organization, same letters though, called Words Matter. So all about this idea of suicide-safe language. Same as Talk Suicide Canada, who runs our national crisis line, also has a page on their website about suicide-safe language as well that I would encourage folks to check out after today. So another way we talked about learning suicide-safe language, another really important way that we can help to kind of dismantle some of the stigma that surrounds suicide in our community is to, get a sense for what are myths that we commonly believe in our community and what is actually the fact. What is the kind of clear, direct truth about suicide? So one super common myth you'll hear is that folks often believe that only somebody with a mental illness will think about suicide, and that suicide is inherently caused by mental illness. We know that is not the case. So for sure, there can be a link between mental illness and suicide. However, anyone has the potential for thoughts of suicide. And there really is often no one cause of suicide. So there are a variety of complex reasons that might lead someone to consider suicide. A mental illness may be one of them, but that's not always the case. This is a huge one. I'm sure many folks have heard this before. Many folks have heard the myth that it is dangerous to talk about suicide, and that asking about suicide directly will actually put the idea in someone's head or encourage them to take action on a suicide plan. What we know is this is actually the exact opposite of what our research indicates. Talking about suicide openly and directly is actually the best way to prevent suicide and to encourage people to connect with help. Asking about suicide will not put the idea in someone's head. And there's a number of reasons why this is a myth. Number one, we as human beings are just not that easily influenced. We have preformed ideas about death and dying. We know about death. We know about suicide from quite a young age. And simply asking a question is not persuasive enough to really change somebody's relationship to quite a serious topic. What we know instead, though, is that when somebody's thinking about suicide, they can often feel quite isolated. They might feel alone. They might feel burdened by the fact that they haven't felt they could talk to anybody about what's going on for them. And so actually providing somebody with that space to say, you know, hey, I'm somebody that will talk to you about this and can help get you support can really help people to feel heard, to feel validated, and to discharge some of those emotions they might be hanging on to. So hopefully after today, if you hear anybody kind of using this idea of, oh, I haven't asked about suicide because I'm afraid I'll convince somebody to do it, that is not the case, and definitely something we can kind of start to combat in our society as well. Another common myth is that we can easily predict who will die by suicide. And we'll often see this with what we call risk assessments. Let me be very clear, it's very important that we're asking people about suicide, that we're doing proper clinical assessments for those of us that are in clinician roles. However, what we sometimes see is people designating people along kind of a spectrum of risk and saying, oh, well, you know, this person hasn't hit the high risk category, so there's no way they're actually going to take action on ending their life, so I don't really need to provide that person with much support. What we actually know, though, is that although we can, with some accuracy, predict who might be at more likelihood to end their life, we cannot always predict who will end up taking steps to end their life. However, we can notice those signs, we can conduct those screenings, and we can make sure that we're casting a broader net for safety interventions. So regardless, whenever somebody's sharing about thoughts of suicide with us, it's really important that if we're the person who's able to provide that support, we're providing that support. And if it's outside of our own kind of professional or personal capacity, that we're connecting that person on to further support where they can get connected to somebody who can help. Another myth we hear often is that all persons with thoughts of suicide are fully convinced that they want to die. So sometimes people will also use this as a reason. We might hear somebody say, oh, you know, well, if they're already at the point where they're considering suicide, what can we do to help? What we know factually, though, is that most people having thoughts of suicide are actually not fully convinced that they want to die. Rather, what they're wanting is a way to escape the situation they're in, to end emotional pain. We know instead, though, that suicide is preventable and thoughts of suicide can be temporary. So getting somebody support in these vulnerable moments is very important. And finally, this is one of my favorites. I teach a lot of workshops in person, and this one comes up all the time. People will often say this idea or bring up this idea of what we call a safety contract. So it is a very commonly held myth that one effective way of helping someone with thoughts of suicide is to create a safety contract. And you might be wondering, what is that? Effectively, what a safety contract is when the helper and the person with thoughts of suicide make an agreement where the helper asks the person with thoughts of suicide, can you promise me that you will not end your life before X date? And you might be wondering, you know, why is this ineffective? Well, when we think about it, when we're asking somebody to promise us to stay safe, what we're actually really doing is that we're trying to resolve our own feelings of uncertainty or anxiety about that person. We're asking the person to stay safe, but we're not really actually working with them to come up with reasons that they want to stay safe. Rather, we're helping them to we're getting them to kind of promise us that they will stay safe, not necessarily even for themselves, but for us as the helper, which can even leave that person feeling like they might be a burden. So research evidence at this point in time does not recommend safety contracting. This is an out-of-date practice. So especially for those of you in healthcare settings that work with people who might be doing suicide risk assessments and safety planning of some form, if somebody's coming up with a safety contract, you can let them know that's no longer best practice. What we know, though, is that professional helpers should be co-creating what we call a safety plan instead. So if you're the person that is the professional helper, I would really encourage you to look up safety planning. That's that collaborative planning with somebody to help them find that motivation to stay connected to life. And if you're not the person who is the professional helper to take them through that process, it's really important that you're connecting the person to whoever it is that is able to help make a safety plan. So we've cleared up a couple myths. We've cleared up some facts. We're talking a little bit about things we can do to reduce stigma, but really wanted to take kind of the latter portion of our time together today to talk about what we can do to help somebody who's thinking about suicide. And again, this concept gets taught in like hours-long workshops. So we're really doing kind of the quick and dirty, but would really encourage some further learning after today as well. So one of the huge things we can do is what you are all already doing here today, and that's to get educated. So using suicide-safe language, learning facts, encouraging those around us to do the same, and registering for other suicide prevention training opportunities. And you can even be an advocate for that training in your workplace. There's lots of great workshops out there. There's something called Applied Suicide Intervention Skills Training, or ASSIST. There's Safe Talk, which is a slightly more introductory version of ASSIST. And there's other options as well, most of which operate through local crisis centers or your local CMHA branch. And I'll highlight those resources at the end as well. You can also start the conversation. So really starting by noticing when somebody might be thinking about suicide, noticing change in somebody. What this could look like could be different for different people. But really what we're looking for is anything that's happening to somebody that we know where we've noticed that something's not quite right. We're quite perceptive as humans. We often notice these things. We can sometimes feel it as like a gut feeling. So really kind of paying attention to those signs. When are we starting to kind of feel worried about somebody? And if we are noticing that somebody in our life, whether that be somebody in our professional life or our personal life, just doesn't quite seem like themselves, we want to make sure that we're asking, we're doing a check-in. And in fact, even asking clearly if someone is thinking about suicide. And the best way to do that is by just coming right out and saying, are you thinking about suicide? It can be a really awkward question to practice. It's not a common thing that we say or talk about in society generally, but it is the best way to get a clear answer from somebody, yes or no, is this something that's on your mind? And if we get that yes, it's really important that we're then doing some listening if we have the capacity to do so, and ultimately connecting that person to further support. In an emergency, we always want to make sure we're calling 911. So my general rule is if there's been risk of bodily harm, so perhaps somebody's already enacted a suicide plan, they're at risk of physical harm, 911 is going to be your go-to because they're going to be able to get you connected to healthcare workers like paramedics, doctors, etc. If you're not sure what to do, if you're not sure who to connect with, you don't know, maybe you notice somebody in your life is struggling and you're like, oh, like I know I could check in, but I don't really know how to do that. A kind of little known fact about the crisis lines is you can actually call the crisis lines as the helper as well. So you can make a call to the number for the crisis lines. You can explain to them, hey, there's this person in my life. I'm really worried about them. Here's what I've noticed. I'm not sure what to do. What can you suggest? What should I be doing in this situation? Sometimes the crisis lines will even do a third-party call out for you. So if there's somebody in your life you're quite worried about, you're not really sure how to do the check-in, you can actually give the crisis line this person's name and phone number, and they'll make the call on your behalf. They do keep it confidential, so you will never know what the result of the phone call is, and the crisis center will not disclose to the person that you're the one that provided the contact details, but they will make that contact and they'll help get that person connected to support, so that is another option available as well. So that takes us to some resources we have available in our community. So for immediate support, there's a lot of great resources out there, and I'm really excited to see the province of BC investing in some really cool alternatives as well to some of the supports we have in place currently. So again, we've got 911. We've got that number that I highlighted right at the outset. That's 1-800-SUICIDE, and that's our kind of go-to access for crisis line support in British Columbia. The province of BC has also invested in what we call peer-assisted care teams, or PACT. These currently operate in Victoria, in New Westminster, and in the North Shore of Vancouver, but they are expanding over the next year. And what PACT is it's a community team, so like a mobile crisis team that pairs two support workers. So one of the support workers is a clinician, a counselor, a social worker, a psychiatric nurse, and they're paired with a peer support worker. So somebody who's received extensive training, who also brings lived expertise to the role. So somebody who's had, whether it be a substance use experience, a suicide experience, or a mental health experience, that's able to really relate to the person they're supporting in crisis. We also have in BC the CAR programs. There's various, they've always got a number after them. It's usually CAR and then 67 or 82. And these operate out of local police departments. So if you're curious if you have a CAR program in your area, there's a few too many for me to list on the slide, but I would encourage you to kind of Google your local police department, check in to see what's available. These teams, similar to PACT, although the difference with CAR programs, they are a mobile team, but they pair a police officer and a psychiatric nurse, so slightly different complement of the team. We also have, for those of you that might be perhaps connecting with or supporting maybe loved ones or colleagues outside of BC, we do have Talk Suicide Canada. That's our national line, which also operates a text service. Kids Help Phone is available in Canada as well to youth, although don't quote me on this. I'm pretty sure they don't check age. So anyone can really call Kids Help Phone, but it is technically a youth service. And then finally, we do also have in BC, actually operating out of Port Alberni on Vancouver Island, the Kuis Indigenous Crisis Line. This number I've listed is their main number, but they do also have a youth line and an elders line as well. So I do really recommend checking out their website to get familiarized with the resources these folks provide. If you're interested in further learning, as we're kind of wrapping up our time together today and moving into Q&A, there's a number of different programs that you can look into. So the Assist and the Safe Talk that I talked about earlier, this is programs that are developed by a company called LivingWorks. They are a Canadian organization that develops suicide prevention curriculums. They are actually internationally recognized. So although they started here, they're operating all across the world now. They've got some online resources at their website, and then their curriculums are also delivered across BC. And CMHA BC actually does have a list of providers of Safe Talk and Assist on our website. So really encourage wherever you are in the province to check that out if you're interested in accessing those resources. The BC Crisis Line Network as well is made up of the 5 regional crisis centers. Each of our health authorities here in British Columbia has a crisis center embedded into that region, and they work together to bring us the 1-800-SUICIDE line. If you're interested in who your local crisis center is, check out that website link. It will have all the crisis centers listed, and most of the crisis centers actually will also have their own curriculum in addition to Assist and Safe Talk to really even meet broader need around kind of that crisis de-escalation learning or suicide prevention learning. I've linked again the Wise Practices website. That's the one we spoke about earlier with life promotion. The website for Talk Suicide Canada, they're who run our national line, but they also do have some great static resources as well. There's also the Center for Suicide Prevention that operates out of Calgary, Alberta, but does service nationally. They've got lots of great resources, infographics, research data, etc., on their website. And then finally, if you do have follow-up questions today, I know my information is going to be shared, but we do also have a general suicide prevention email at CMHA. So you're welcome to contact me at that email address, me or a team member of mine. That's suicideprevention@cmha.bc.ca. So wrapping up for the day, I see there's a couple questions in the chat. Thank you for kind of coming with me on this whirlwind, quick and dirty intro to suicide prevention. I hope folks are able to take away, even if it's just one myth that you're like, you know what? I really thought that was a thing, and after today I've changed. That feels like a huge success to me. So we'll leave some space for questions. We'll probably wrap up a little bit before the hour, and really, again, encourage if you're interested in connecting with CMHA, our information's there as well. I'm going to stop my screen sharing.
Thank you, Maria. Yeah, we have few questions here. Okay. Folks are asking if the presentation will be shared with them. And I think it's a good opportunity for us at Care for Caregivers to post this information on our website. So for sure, it's going to be website content that it will be shared with all the audience.
I'm typing a response right now.
Yeah.
Awesome. Yes. So I have, it sounds like we've recorded today's webinar. So it'll all be available online as well. So that'll be the live recording. And yeah, I'm comfortable with the PowerPoint being shared as well. I see somebody's asked specifically and given an email. So Siboney, if you're comfortable, I'll maybe just send you a PDF of it and you can maybe circulate to the group. Yeah.
That's perfect. Thank you, Maria.
Nah, no worries. I noticed there's another question, and oh, this is a real can of worms, but it's a great question. Is there any idea how MAID could impact this support moving forward? I'm hopeful there's additional training for people that are thinking of doing MAID and how we can better assist people, for sure. So that's something that comes up a lot in the work that I've been doing, especially as Canada gears up to a legalized MAID for folks whose primary or sole concern is related to mental health and mental illness. Just to be super clear, it's not legal yet, so it's not a consideration in terms of it really shouldn't be being offered to people at this point in time because it is not a legal option for MAID currently in Canada. But definitely this is a conversation that we're having actually at the CMHA national level. So we do have we're a federated organization. So CMHA national is in communication with the federal government about ways in which these kind of topics will intersect, because you're absolutely right. There are, implications, where does somebody's request for MAID become suicide and where is suicide not MAID? And, it's a real ethical quagmire that I think at this point in time, without the specifics around what MAID for mental illness will look like in our country, it's hard to give kind of a concrete answer. But I would echo that, from our vantage point and many of the folks doing advocacy and support in this space, there's definitely a need for training, for really clear information, for safeguards, for policies, procedures to be put in place to make sure that people can access the support when it's needed and appropriate, and that people that are not needing that support are not maybe being offered it inappropriately. So yeah, great question. Any other questions from folks? That's myself. I'm back on the screen. That's funny. All right. Well, it looks like we've only just had a few questions today. Feel free. Oh, that's so lovely. Somebody gave just a nice comment in the Q&A. Thank you, anonymous attendee. Much appreciated. Feel free to reach out if anything comes up in terms of questions that you might have after today's presentation and you're thinking, shoot, I wish I'd asked this on the live webinar. That's okay. My contact details will be shared and I'm happy to chat offline as well. And then Siboney, maybe I'll just pass things back to you to kind of take it away from here.
Thank you, Maria. Yeah. We will send you an email afterwards this webinar to share with you the website links that they were in the presentation, Maria's email address, and then that way you can feel free to connect with her directly if you have more questions or concerns. I would like to remind everyone about our upcoming webinars. September 21st, we have a What to Say When You Don't Know What to Say, how to respond to difficult conversations and questions in the healthcare setting. October 3rd, we have Flexible Adaptation in Relentless, Emergent, and Inevitable Change. October 12th, we have Responding to Crisis at Work. It's going to be presented by Maria Weaver, now that we have her here. October 25th, Healing from the Impact of Trauma. So please visit the Care for Caregivers website to register. I will also like to remind you about our Care to Speak program, which is a peer-based phone, text, and web chat service that provides free, confidential, and unbiased support to health and social support workers in BC. You can also find our 8 different episodes as part of our podcast series, Care to Listen, on our website. And also, I want to thank you, Maria, for such great presentation, a very relevant and important topic to reduce the stigma, raise awareness, and strengthen prevention. Thank you everyone for attending this webinar. Please take some time to answer our survey once you exit the webinar. Your feedback is highly important to us to continue bringing valuable content to you. So thank you everyone again. I would like to, oh, there is one more question here.
Sorry, I just put my hand up. I was like, wait, there's a really good question.
Yeah.
So I got a really, really great question in the chat here saying, how would you initiate a conversation with a healthcare practitioner about shifting to safety planning who may currently be utilizing safety contracting in practice instead? Without knowing, and I don't want to necessarily like de-anonymize questions on the live. So if you're comfortable reaching out to me further, I think this is a great conversation. I would be happy to support the specifics offline. But I would say the first consideration I would have is looking into kind of what is your professional relationship to this person? If they're lateral or they're down a power dynamic, I think it's much easier to have the conversation around, hey, you could even say you watched a webinar, like, hey, I watched this really cool webinar. Here's what I learned. I wonder if we should be implementing this into our practice and kind of make it more of kind of a collaborative, like I'm sharing information with you as opposed to kind of a scolding, like you're doing this wrong. If you're in a leadership role and you're in charge of this person, I think it's totally fair game to say, hey, we're updating our practice here, and this is our expectation of what we're doing moving forwards. Same, I would look into what your organizational policies look like. Like you may have practice standards in your healthcare setting, depending on this person's professional credentials, like perhaps they're governed by College of Physicians and Surgeons, et cetera. You can always kind of look into what specifically governs their work, and you may be even able to point back to the reference document, the policies, the procedures. But I think, yeah, as much as you feel safe and comfortable having these conversations, if you're in the power position, I say go for it. I think people really like you have that capacity to make it a mandate. And if you're not, if it's lateral or it's up a power dynamic, kind of approaching it from that place of curiosity, of sharing, of, here's what I learned, using that we language. Can we maybe make this a practice? Even maybe approaching your supervisor, if there's somebody who oversees the healthcare providers that you think is able to kind of implement that change workplace-wide. I think there's kind of a few different avenues you could pursue. So definitely, if you want to talk through the specifics of your particular workplace, I'm more than happy to discuss confidentially offline as well. But yeah, great question. And the fact that you're even considering this, I think is incredible. So thank you. Yeah.
Thank you, Maria. Thank you for raising your hand.
Yeah, I wanted to catch it before we sign off.
A very important question. Yeah. No, we have here a comment. Thank you, quick and informative. So, thank you, everyone. I know we finished our webinar before the hour, and we will continue uploading more content on our website. To continue learning. So once again, thank you, and have a nice rest of your day. Thank you, Marianne, everyone. Bye for now.